Okay, it's 6:30. I think we'll get started. So, good evening. I'm John Wyan, a member of the St. James Mercy Health System Board of Directors, and it's my privilege to welcome you to our second town meeting. My fellow directors and I are touched by your presence and interest tonight. As someone working in our system, living in our community, being served by our talented colleagues and professionals, I'm confident you agree our health system is more than a community resource, it's a community treasure. St. James Mercy Health System has been serving this community for nearly 125 years. We know that a community can only be as vibrant as its healthcare presence. Working in concert with our board, many people in the community and within St. James have been working hard to ensure a sustainable healthcare presence in Hornell for many, many years to come. We would not be at this gathering today if not for the leadership of St. James Mercy Health System's president, Jen Sullivan, who will be addressing and answering your questions this evening. After a decade of service to our ministry, during which she's worn many hats, including Chief Financial Officer, Jen was named interim president and CEO on August 2013 and permanent CEO in February 2014. In her short time at the helm of our ministry, we've seen Jen build new relationships and strengthen existing ones. We have seen her engage the community and listen to its needs and concerns. We have seen her respond to the community needs with a vision, a very strong vision that is proper, necessary, and within our reach. There's still a lot of work to be done, and the board of directors is confident we're well on our way. So, ladies and gentlemen, please welcome Jen Sullivan.
Thank you. I'd like to start tonight by introducing the senior leadership team who is sitting up here with me. We have Patty Dagan, she's our nursing home administrator, here on the far right in the pink. Kathy Broadbeck is our chief nursing officer, right here. Stan Konopko is our chief financial officer. And then Dr. Carroll is our chief medical officer. I'm not sure if everyone in the room knows them, but ask them to join me up here this evening. What I'd like to get started with at the beginning is to basically think about where we started. And at the last town hall meeting was in February, and I introduced you to the New Vision Task Force. I introduced you not only to the members, but what their mission was and how what they were charged with, how vital it was to our next steps. We shared with you that St. James continues to be a source of pride for the community, and we introduced you to some initiatives that we were rolling out in the community, our Center for Orthopedic Care, Express Care, etc., and we asked for your support. And we've received great support from the community, and I do want to thank you. In the town hall meeting tonight, we have a few objectives. One is I'd like to talk to you about the significant progress we have made. We've identified resources, not only financial, but human resources as well, to continue forward on our path and our transformation. I want to recognize the members of the New Vision Task Force, because when we last met, that group was knee-deep into actually it was probably higher than knee-deep, eyeball deep into preparing the business plan, and so much has occurred since that date, and talk to you about next steps. So, where were we? The visual picture of the path. Starting at the bottom, where we started, we had huge challenges that we face here in Hornell. And those challenges still exist, and they reflect challenges that we're seeing not only here, but across the country. So why the transformation? And I know this is a bit of a repeat from the first town hall meeting, but it's because our financial situation was untenable, and we cannot continue to lose money and succeed. Nobody could. And so where we started in explaining in the last town hall meeting why the transformation is needed is really largely related to what's happening in the healthcare industry. You have increased competitive pressures, competition. Your reimbursement is declining, so if you perform the same services you do today that you did yesterday, you're going to get paid less for it. we have economic crises, there's been a continued decline for inpatient utilization. And what that means is the lower the inpatient utilization, the less revenue you generate, because you generate more revenue on the inpatient side than the outpatient side. That being said, we have 119 licensed beds. Our average daily census is 12. And so you can see that the transformation at St. James has pretty much occurred. I mean, most of what we do today is on an outpatient basis. It does not mean you don't need some level of inpatient care, but that's not where most of what we do is. And that's what creates a lot of the revenue challenges that we face, and then it makes it increasingly difficult to cover your expenses. So if you look at where we were with the New Vision Task Force, you may recall that our board of directors called for the formation of that team back in December, and that team was charged with exploring options for a sustainable healthcare presence in Hornell and the surrounding area. It did require thorough, strategic, and objective reviews of the services we offer, and it did require forward thinking and candor. You may recall that the task force that helped us put together our business plan for a sustainable solution to preserve healthcare in the community was made up of business leaders, physicians, healthcare experts, and financial professionals. Did that move? Yeah, I guess it did. So when you think about where the task force is today, I can tell you that they did complete their business plan. Again, when we met in the middle of February, they were working on it. They completed the business plan. We presented it to potential tertiary partners in March. We presented it to the board. We selected a partner that we would like to work with. And we also used that business plan to identify funding through the New York State Department of Health that will help us sustain our operations through early 2015. And so you may recall that I think it was April 30th, it's hard to forget some of the dates when you have this many big things going on at the same time, but we did make those two important announcements. We had selected an organization that we'd like to work with as we move forward with next steps, and two, is we did identify a source of funding to help us sustain operations. And I think when we were here in February, there was that urgency, and that urgency is still here, but the Department of Health has come forward with some funding options for us to help us sustain operations while we transform. And really what we focused on with the New Vision for Healthcare in Hornell was really focused on the Hornell region. And when you think about what the rest of the state is doing and what the rest of the country is doing, when you become financially more viable and you're in a rural area and there's others nearby, one becomes financially viable at the expense of the other. And so what happens is it's a vicious cycle. So, one becomes more, stronger, then the other becomes weaker, and it's not solving anything. All it's doing is just creating tension and stress, and it's not solving the situation that we all are faced with. Each rural community has certain needs that they all need. There's also opportunities to collaborate and work together to achieve financial sustainability going forward. And so when we met with the Department of Health, the challenge that was posed to us, and again, it's not just us, you're seeing this across the state, was basically, you need to think bigger, you need to think broader. Your vision is great, you did a great job, you showed how you could obtain financial sustainability in Hornell and the surrounding area, but you know what? You're going to do that at somebody else's expense. And we're not looking at that. We're looking for an answer going forward. So we want you to think broader and more regionally. So what they did is they sent us back to the drawing board, if you will, and said, now take your New Vision business plan and develop it further. And so that's really where we are today. The challenge for us at that point in time was cash. You need cash to survive. You can't take your time and develop something to be bigger and better if you have no money to do it. And that's where the state was saying, well, then we'll help you with dollars to sustain operations while you're transforming to something that's more sustainable for the region and isn't just solely focused on one community. So what happened is the federal government there's about $8 billion coming into the state to help communities and healthcare providers transform their operations to something that's sustainable and financially viable in the future. But if you want that money to transform, and you need the money, so remember at the last town hall meeting we talked about a new building. You know, we know that we can't continue to operate out of the facility that we're in today the way it is today. So what you think is you have two options. You renovate what you have or you build something new. But to do either one, you need money. And so the state's basically saying if you want some of that money, then you're going to collaborate with others. If you're going to work by yourself and you have a vision just for you, you're not going to get it. And so really that's the fact of where we're at, looking to take what we have already developed and grow it further. So where is the New Vision Task Force today? They're basically standing ready to reconvene as we continue to pursue, develop, and implement our new vision. So as you may recall, when we met in February, they were meeting every Friday, and they met every Friday for 3 months, January, February, and March. It was a lot of work, it was very aggressive, and now we made our announcement at the end of April, and they're standing ready to reconvene. So we do thank them for their work, their expertise. I have a picture of them up here for those who may not have been at the first town hall meeting, and just really would like to thank them for leading us to this first, or through the first phase and the completion of the business plan. So where are we today? I guess I'll look at my notes. I mean, I know where we are, but I like notes. Lots of paper and notes. So you know we've made significant progress. I will talk about where we're going next, but we have a lot of work to do. So if you look at the picture on the screen, you know we started at the bottom. We made it halfway up this hill, but there's still the rest of the hill to get up. And so I wanted everyone to understand that there's still a lot of work left to do. So why did we select UR Medicine? Why did we want to work with that group? Basically, they share our vision for healthcare in the community and the surrounding area. They offer administrative and medical expertise that we need to realize the new vision. They already have an established regional presence. They seem to be very and sincerely interested in this opportunity, and you can tell when you meet with someone if they're interested or not, and they are sincerely interested, and they've dedicated significant resources to planning already. And they are working with us to secure funds needed to realize the new vision. Nothing's a guarantee, but we selected them for many reasons, and those are several of the reasons why. So where do we go next? Well, we need to apply for that funding, so we know the $8 billion comes into the state, but how do we get it? And the state set up something called an Interim Access Assurance Fund. And so there's actually this application we have to fill out, and nothing's easy. You know, we need to go through and complete that. And that will allow us to sustain operations through early 2015. Again, as I mentioned earlier, that will give us time to pursue our transformation and ensure we can continue to provide services. So this application is due by the end of the month, which is, I think, next Friday. And so we really haven't, you know, been able to really take a breath. We just keep moving very rapidly forward. We pretty much feel we'll get that funding. We're optimistic, but nonetheless, we need to go through the process, the formal process, and submit the application. Again, as I mentioned earlier, we did have 2 significant announcements on April 30th. Again, the selection of UR Medicine to work with us. They're helping us with our plan to preserve quality healthcare services in Hornell. Again, as I mentioned earlier as well, we need to take that new vision for healthcare in Hornell and we need to move it to the next step. We need to work not only with the university, but with other healthcare providers in the region to explore how can we solve the issue in a more sustainable, collaborative, regional way, so you're not competing where one gets stronger at the expense of the other, because this healthcare issue needs to be solved across the region, not only in Hornell. So we do plan to work with the university. They are a much larger organization, obviously, to apply for district funding, and that's called Delivery System Reform Funding. That's the next level of funding, and I don't want to kill you with all the hoary-gory details, but that really is another part of that $8 billion to help the region transform to something that's sustainable and financially viable going forward. We need to determine what the exact relationship is. You know, what will that partnership look like as a result of the due diligence? So through due diligence, we're sharing information. You know, first you share information to say, well, do they want to work with us? And they decided they wanted to work with us, but that's just the beginning. There's a lot more of sharing information to say, well, what would this potential collaboration or partnership look like, and who else would be involved? And what services are going to be where? And again, I wish I had the details to tell you what services will be provided in Hornell tonight. And as the work of the new vision for healthcare in Hornell, I had a little bit of a clearer picture. But as you expand that to a broader look at the region, and you look at what's happening across the state, you can say, I don't know what'll end up where. You know, you first need to talk with the others in the region and figure that out. So we're really in step 2, I guess, is the best way to put that. We did have a couple announcements this morning about the nursing home. You may or may not have seen those as of yet. We're thinking about transformation in 2 ways at this point. We certainly need to address long-term care transformation. The community needs long-term care, skilled nursing facility services. We also need acute care services, whether you're talking about it on the inpatient side or the outpatient side. We know the focus here for what our community needs most of the time is outpatient, but there is a need for some limited inpatient presence, and what that looks like, I can't tell you today. But we decided that the best course for Mercy Care going forward is to sell that to an organization that specializes in long-term care. What we're doing is keeping our eye on the goal. The goal is we need to ensure the long-term success of our long-term care facility. So the good news is we envision that it's very much part of the services going forward. And the good news is we're selling it to somebody who focuses on long-term care, because what you don't want to do is have one take the back seat to the other. We need to complete 2 transformations at the same time: long-term care transformation and our transition to an outpatient-focused organization. And so we feel that's in the best interest of the community to ensure the long-term continued presence of that. We also announced that we are closing our ventilator unit. We have 3 patients or 3 residents in the unit. It's not a service we can afford to continue with such a low demand. There's a very low demand for that service in our community. So what we're looking to do is relocate those 3 residents to facilities closer to their families. Once that occurs, then we would close the ventilator unit. So we're no longer accepting new residents, and we're looking to relocate those that are there today. So those were 2 announcements that were shared today. We met with the residents and the employees over at the nursing home this morning. We had internal communications go out and a press releases as well. In keeping with the New York State delivery system reform goals, again, and I know we've talked about this many times, we're transitioning from traditional hospital-based care to a more robust array of outpatient-focused services. And again, that is clearly, when you look at the data, it's data-driven. That is what our community needs most of the time. Again, I'm not saying there isn't a need for inpatient care from time to time, but what our community is using most of the time are the outpatient services. The goal of New York State, and part of that $8 billion of funding, is to reduce avoidable hospital use. And they look at that in 2 ways. One is they're saying we can reduce this by 25% if you improve your ambulatory care system. You have a more robust outpatient array of services. And what that means is they want to prevent you from getting sick and keep you well. And so they're basically saying, if you think of the traditional hospital, emergency care is expensive, and not all emergency care, you can avoid some emergencies if you take care of yourselves, and we have wellness and prevention programs. And the same thing on inpatient admission. So that's really what the overall goal is, to reduce avoidable hospital use by 25%. And again, that's what healthcare providers across the state and actually across the nation are trying to achieve, and that's why it's such a difficult, challenge. There's been tons of questions recently related to OBGYN, and I cannot even begin to explain to you how many rumors I hear on a daily basis, and it's hard. I hear them too. I don't know where they come from, and all we do is try to give you the facts, and the facts speak for themselves. We are not closing maternity. We do still provide OBGYN care. We have 3 providers here that provide those services. We still have a birthing center, and I just wanted you to know that. Dr. Rupert is going to be affiliating with Jones Memorial Hospital beginning July 28th, and his patients can decide where they'd like to go for their care. We're trying to make that transition as collaborative as we can so we can preserve women's health care services in the region. And again, we're trying to get away from that mindset that we're all competing. At some point, we need to work together to ensure our communities have access to the services they need. In terms of new initiatives driving us towards our ambulatory focused model of care, just wanted to again touch on some of the things we've done. So at the same time we're doing the strategic planning for the new vision for a sustainable healthcare presence in the community going forward, we did open our orthopedic center in January, our progressive care center in March, our express care center in March, and our patient access center in April. So I don't want you to think that the operations of our hospital are taking a back seat to the transformation and the strategy of the new vision, because we really, I think, are doing a really nice job moving both forward at the same time. So where are we going? I think where we're going next is a sustainable healthcare future. I'm optimistic that we will be able to achieve a regional collaborative solution. We need to continue working with the Department of Health, the University of Rochester Medical Center, other healthcare providers in the region. I don't care if we call it New Vision Part 2 instead of for healthcare in Hornell, for healthcare in the region, but somehow we need to come up with a sustainable, financially viable solution so the people in our community have continued access to care. Whoops. So with that, and before I open this up to questions, I would like to introduce Steve Goldstein. He is the president and CEO of Strong Memorial Hospital, and as I mentioned earlier, we are working with them. He is here with us tonight. And the announcement to work with the university is actually a milestone for us here at St. James. It would not have been possible without Steve's leadership, collaboration, and vision. So I want to thank Steve and invite him up to the podium to share some words with you. Thank you.
Well, thank you, Jen. Jen said a lot. Let me introduce, by the way, a couple of people from the university. Michelle Lawrence. Michelle is our regional director, and Kathy Parinello, who's our chief operating officer at Strong. As Jen mentioned, my name is Steve Goldstein, and I'm the president and CEO of not only Strong Memorial Hospital, but also Highland Hospital. I also work with, we are 3 hospitals, which is F.F. Thompson in Canandaigua, and I also work with them. But most important, I view myself as a New Yorker. I will tell you that not only born and raised, but also for the last 32 years, I know I don't look that old, I have worked in Rochester, and I've been CEO of 3 of the 4 hospitals. I used to be president of Rochester General up until 1996, and then went over to Strong and Highland. So I have a sense of not only our community, but I've also had the advantage, and this has been an enormous advantage, of having been on the Hospital Association of New York's Board of Directors for now over 25 years, and actually having been the chair of that organization, and also served a term very recently as on the Board of Directors of the American Hospital Association, which represents 6,000 hospitals throughout the country. And what I learned on that was that the kinds of issues that we're watching in Hornell are really hitting a lot of different communities throughout the United States. We are in as Jen mentioned, we are in a transformation. And while it's very painful for communities who find their acute care facilities diminishing in size and having to transform into other levels of care without potentially the financial resources to make that happen, because I can tell you that with new codes as a result of, and very importantly and very valid as a result of some of the natural tragedies that we've had through Sandy and tornadoes, etc., hospital codes have become very complicated and very specific. And hospital construction is very expensive. And so what we're watching is, whether it's inpatient facilities or outpatient facilities, it's quite expensive to renovate and to transform those facilities. That is an issue we are trying to sort through as we look at the current inpatient facility and how it can be used for new levels of care. We have, I think, a lot of experience. We just recently acquired the facilities at Lakeside Hospital in Brockport, and we're attempting to do the same thing there by transforming those inpatient facilities to outpatient facilities for that community. We've found, and somewhat to our dismay, that the renovation of those facilities has been enormously expensive. And so we have been very diligent in trying to work with New York State and understand what resources we can bring to the community as the transformation is made. I should back up and talk a little bit about the transformation, because there are aspects of it that are very important for the state. In my time in Rochester, I've watched probably 50 hospitals in New York State that have gone from either inpatient facilities to outpatient facilities or have closed completely. And if you look at Rochester, Rochester actually has had the experience of Genesee Hospital closing, of St. Mary's Hospital. We have gone from 6 to 4, but yet then Lakeside, which was in Monroe County, so that closed, 3 hospitals closed. And there are a number of others that are faced with the dilemma of a reshaping of a healthcare market. Why does the market have to reshape? Well, New York State is really focused on, and what DISTRIP is really focused on doing, and there are actually 2 sources of income, or 2 sources of money for this transformation. One is for capital, and the other is for, as Jen explained, a transformational approach to trying to health plan for communities. New York State has a budget of around $140 billion, of which around $55 billion is Medicaid. 25% roughly of all New Yorkers are on Medicaid. That is every time I say that, I get chills. It's a shocking number. But you have to consider that of the 54 or 55 billion for Medicaid, roughly half, roughly 23, 24 billion of that is long-term care. And so you have a connection of long-term care and inpatient care, and that results in a state obligation, which is about 50% for Medicaid. And New York State's been struggling with this. And I've been around, as I mentioned, a long time, and I've watched year after year cuts in Medicaid. Our physicians are frequently asked to accept incredibly low reimbursement for their time, and it's almost impossible to have a practice that serves only Medicaid patients or a majority of Medicaid patients. from a payment point of view. But remember, these are New Yorkers that need care, and they need care that's coordinated, and they need care that is complete. And so what the state is attempting to do is make sense of this. And I give a great deal of credit to Governor Cuomo, who a number of years ago said, rather than just have cuts every year and let the industry figure it out, we're going to evolve to what's called Medicaid managed care. And over the next year or so, all Medicaid payments will be in a managed care environment where there will be a global amount and organizations will be called upon to manage within that. Well, we've been in that global cap for a number of years. And interestingly enough, hospitalizations have reduced, emergency visits have reduced, and the state has been able to save money. And that was the basis of going to the federal government and saying, we have saved upwards of $3 to $4 billion a year in Medicaid expense. The federal government, therefore, pays less because they have a 50% share. We would like some of those dollars back for the state so that we can transform care in a way that will permanently be beneficial for our citizens. And that is the nature of DSRIP. It really divides the state into 14 locations and calls upon lead organizations to work with a multitude of organizations to try and figure out how to organize care in a way that's logical for communities so that we can prevent the kind of disruptions and that we're seeing not only in Hornell, but in many, many other communities in New York State. The university is a large organization. We have roughly 21,000 employees. We're spread not only between multiple hospitals, but also primary care sites, and we extend ourselves throughout upstate New York. And as a result, we have indicated to the state that we would be willing to be what's called a lead organization. And over the last few weeks, and if we look tired and exhausted from all of this, we've had close to 100 organizations approach us to say, how can we work together in a multitude of ways to bring better care to our community? And we are attempting to create a plan over time for many of those communities with their local organizations that will achieve that and bring some of those fundings to the local communities. Our goal would be to work with those communities because we have what we believe is one of the great assets that every university has, and that is that we produce medical manpower. In fact, some of that manpower is in Hornell. Many of your medical staff have trained at our university, have relationships with our university. We have about 600 residents that are trained there and about 175 specialists that are trained in fellowships. And about 35% of them stay within upstate New York. So we always feel that if we can understand the healthcare needs of a community, we can steer some of our trained professionals to service those communities for generations to come. So we believe that's a very logical extension of what a university does. Over the last number of years, we've developed collaborating relationships. We don't own them. They're not part of the balance sheet of the university. But we have a collaborating relationship with Jones Memorial, with Dansville, with Wyoming County. And now we have been involved in the transformation of care within Brockport. And that has given us a great deal of information, a great deal of experience in not only the needs of the communities, but how we as an organization can extend ourselves to try and help that organization help itself provide health care for its citizens. So we're very excited. We thank the board. We thank the New Vision Committee. It's really been an honor working with Jen and Stan and staff to try and understand how we can be helpful. Our goal is to work closely with New York State to try and bring some of that funding to Hornell so that you can actually have the vision of what the New Vision Committee has looked at. We think that there are pieces, however, as we looked at the original document, that are going to be difficult. Jen mentioned, how are we going to work with multiple communities? One of our goals is to try and figure that out so that no one community is disadvantaged as a result, but that point in fact, the lake rises as a result of all of this. And so that's one of our goals. I would mention, just because I'm required to, that it's very difficult to get people to talk and plan about services prior to the actuation of this application because of antitrust and other kinds of rules that our government has put in place, very logical rules. And we're trying to work our way through that and with Stan and with Jen and other representatives, some of your legal counsel, talk to the Department of Health about how we can move some of these applications forward and really give you substance to what is the vision of the New Vision Committee. I don't think that all of the programs that have been discussed will happen, because the reality is that we have to look at what are needs. And so we're very focused now on trying to understand the needs of the community. We've been working with the medical staff. We've had representatives of our medical staff meeting with representatives of your medical staff to try and understand what the needs are. And I will tell you that you have a very articulate group of hardworking professionals that have devoted their careers to this community, and they want to make sure that what plays out over time secures health care for the community. So we're in the process of trying to figure out how to make that happen. We're frankly trying to do it without the university having large financial impact, because what we've learned is that these facilities and others have to be sustainable. Hospitals are businesses, they're big businesses. 65% of what we do are payrolls and other things, and we have to make sure that there's volume and reimbursement that allows us to sustain the programs that are placed in the community, and that the programs that are placed are truly needed in the community. So we have a long road ahead. The picture that Jen showed is really the right picture. It's a road with curves that goes up and down, and I can tell you as a aging hospital administrator in New York State that anytime you're working with the Department of Health and the federal government and trying to sort through how do you bring resources to whatever you're trying to bring, there are always ups and downs in that effort. But the important point is where you end up, never where you start. So again, on behalf of the university, we would like to thank you for the opportunity to work with you as a community. This is obviously a very important and a very trying time. We appreciate that. We understand it. We've been a part of this, and we are going to do everything we can to ensure that the Department of Health, New York State, and all of the assets that might be available through the governor's budget and others can be brought to bear to attempt to provide services. So thank you again. Be happy to answer later any questions that you have.
Thank you, Steve.
Not quite sure where to sit.
Can I sit here?
Thank you.
How are we doing time-wise? We're doing good. So I guess at this point in time, I'd like to open up the floor for questions. I'm trying to see who has Laura, do you have a mic? And Linda does over here. So if anyone has any questions, we'd be happy to try to answer those for you.
Thank you. I've listened now, worse than going to church. I have heard a lot of talks, but I haven't heard any specifics. What I'd like to know is, the people from Hornell going to be hospitalized in Dansville and Wellsville or not?
That is not a question that we can answer at this time because the decision has not been made on
You're
that.
talking about not competing, cooperating. Right now, Hornell is the most vulnerable position because the hospital was mismanaged for many years. So obviously, my concept would be to have one larger hospital here, eliminate Dansville, Wallsville, and Hornell, and build one central hospital about the size of Arnold Ogden and Elmira, because then we could have most of our care in this locale. As I see it, Hornell is going to wind up in a very poor situation because, like I see the statistics there, you don't have any patients in. We've lost all of our periphery. The people from Woodhull, Cohocton, they're going to Corning. The other ones are going to Dansville, and the other ones are going to Wallsville. So we have no periphery, and we don't have enough people here. So obviously, if I can see that you're not going to have a hospital here for any illnesses, you're not going to be able to keep surgeons here if they're going to do minor league surgery. You're not going to have specialists here. You're going to have a very, it's ironic that people in the 30s, the hospitals had a bad reputation because every time you went there, you died. Now we have the opposite situation. Everybody has insurance, but you can't get in the hospital. And I listened to Dr. Goldstein. There's a lot of governmental in their involvement in this. And it is, from what I see here, the people in the rural communities are going to get the short end of the stick. Now, I think that from what Dr. Goldstein said, they have a strong relationship with Dansville and Wellsville, but not with Hornell. And unfortunately, that was ruptured a number of years ago. But you're not giving us any specifics, and I think you do know. I think Dr. Goldstein knows. He's, Rochester is just a typical story of the little fish being gobbled up by the big fish. Rochester down to Rochester General and Strong. And they have taken over all the hospitals up in the Rochester area. I understand Unity, which was a fairly large hospital, is now going to be under the aegis of Rochester General. And I think in this area, I see that we will not have a hospital. Now, as far as the buildings you have, there was one building is not that old. That is the central building where the emergency room is and the surgical department and the OB. Why can't you rehab that building and eliminate the other building? That building was built in the 60s. It's not that old.
Yeah, I would agree. That is part of the analysis. Would it make more sense to renovate versus build new? I will tell you that 43% of the care we provide on an outpatient basis is to Medicaid, uninsured, and dual eligible individuals, and 66% of what we do on the inpatient side. So the reason that it's not a financially viable situation is because the reimbursement is so low. But I will tell you that the decline we've seen in inpatient utilization, nobody is saying here that there is not a need for some level of inpatient care. What we're saying is if you look at the trends over the last 10 years, not only in Hornell, but in Noyes, in Wellsville, across the country, there's better care on the outpatient side, and people are they're weller, they're getting prevention, they have more drugs to take care of them. We don't need as much inpatient care as we used to. So nobody's saying there isn't a need. Every community wants to have the inpatient beds. I think the long and short of it is very expensive to run a hospital that doesn't have a lot of inpatients in it. And so the question is, and the challenge posed to us by the New York State Department of Health is, don't just think about Hornell, you need to think about the bigger region. And we're going to let the numbers make the decisions. It's not going to be what community wants what, because every community wants to keep their hospital. So what's happening is it's becoming a very data-driven process, and that will help lead some of the answers. So we don't know the answers, and really when we met with the Department of Health 1 month ago, they put this new challenge on the table. So I think the work of the New Vision Task Force was phenomenal. I think the work of a regional team could be just as good, and I look forward to finding a solution where we can achieve financial sustainability. And right now, the rural hospitals are all on a path of going out of business, and that won't serve any of our communities well. So it's not an easy answer. It's a tough dilemma, but that really is the reality we're faced with today. And I thank you for your comments.
Well, you're an excellent speaker, and you're very good at talking and just saying a lot of things, but not saying anything. Thank you.
You're welcome. Thank you. Other questions?
Obamacare becoming a lot of Obamacare is going to be they're encouraging people to join Medicaid. Is that going to affect the revenues for the hospital?
I think the challenge is, as if there's more Medicaid, theoretically there could be more revenue, but there could also be people that have commercial payers that pay higher, and so it's how does that mix change? I'm not sure if...
So you're looking at overall, you think the hospital will be getting more revenue rather than lower rates for everybody?
Well, there's an offset because you get more, you could theoretically say, well, there's more people who are uninsured who now have coverage through Medicaid. But then there's the offset where the government's taking $10 to $13 million out of our reimbursement system, saying one should offset the other. The problem is the timeline and how it will occur. And so when you think of cash flow, the declines in your reimbursement rates and the pace of increasing those on the Medicaid rolls, there's so many factors that impact the finances.
Too hard to tell.
It's very difficult to tell, yes.
Yeah, I guess it's better to get some money than no money.
Pardon me?
I guess it's better to get some money, even at a lower reimbursement rate, than it is to get no money at all for totally uninsured people.
Would you like to?
Well, I just would comment. By the way, much to the dismay of my in-laws, I'm not a doctor. My father-in-law was a very eminent physician in St. Louis, and when my wife of 45 years brought me home, he said, he's a hospital administrator. I guess he's the best of bad choices. Anyway, I see a lot of changes in what are historic admissions. If you look at a hospital 10 years ago, you would see 40, 50 inpatients per day. Today, you're down to 12, sometimes 9, sometimes less. New York State and the federal government, Medicare, and third parties are on this quest to really reduce hospitalization. And why is that? The primary reason is that hospitals are the most expensive part of a continuum of care. They are enormously expensive for all the reasons that I talked about. It's not just about having a few beds. It's about having 24/7 staff and all of the facilities that go, the diagnostic testing and all of the systems that have to be put in place, not the least of which are very expensive electronic information systems that have to be put in place to really meet the requirements of a modern-day institution. So as these inpatient admissions get reduced, even though there may be, and I think over the last, since the introduction of the Affordable Care Act, which was, I guess was March 23rd, 2010, there have been about 400,000, I think, New Yorkers that have signed up, and I would guess about half of them have been on Medicaid. So I do believe that there'll be more paying customers, if you will, for these institutions. but in no way will that offset the decline that we're watching in hospitalizations and the efforts that the state has made to try and make sense of that. I would take you back a few years. There was what was called the Berger Commission, which looked at hospitals in New York State and how many of them were necessary, and 11 of them were closed as a result. So it's been a steady drumbeat. And of course, the hope is that if you can be in partnership with your medical community and you can be in partnership with your third parties, insurance companies and Medicare and Medicaid, and make sense of, as Jen talked about, preventive medicine as well as what services can be provided to really assist patients so that they're not admitted to the most expensive piece of the healthcare system as frequently as they have in the past, you can have a more efficient system. And by efficiency, let's be clear that one of the fundamental issues of health reform was cost. America is faced with 17.6% of its gross national product being in healthcare. But even at that level, which is twice as high as other industrialized nations throughout the world, we had 54 million people who lacked access by not having health insurance. That has come down because of employment. Most people have access to health care through their employers. So we had 47 million. Health reform thus far has added another 8 million that have insurance, but we still have a long way to go. And one of the very real requirements of institutions, hospitals, is that they must take care of everybody regardless of their ability to pay anything when they come through our doors. And so that really requires that you have financial sustainability to allow you to have the supplies and the procedures and retain the staff and attract physicians and others to take care of a community. So it's a very complex piece, but I think the points were very well taken. I don't see other institutions closing their doors and building a single hospital. It would be very expensive. It would be in the $65 to $70 million range, and I don't see that happening. So we're really focused on how to provide a community of services throughout large communities. Yes. We actually are. I'll repeat the question. The question was, what is the inpatient census at Strong Memorial? And I will tell you that we're an 820-bed university hospital, and over the course of the year, we are pretty well full. We have 35% of our patients that are considered what's called tertiary and quaternary patients, or 26% of our patients, that are tertiary and quaternary, and that's the NICU, and that's burn unit, and that's transplant. And those are all the kinds of services that only a few hospitals actually within the state and actually around the United States offer. Part of the reason that we're so full is a function of the closure of Genesee Hospital, St. Mary's Hospital. Rochester has about 2.1 beds per thousand. If you looked at Buffalo, they have, for example, I think it's somewhere closer to 7 beds per thousand. They still have some real capacity issues. So Rochester has gone through a period of real consolidation, and there's still some of that. You mentioned that Unity Hospital and RGH were coming together to look at how to provide services in a more cohesive way. We've done the same thing with Highland Hospital and F.F. Thompson in Canandaigua. And that's just part of the attempt on the part of the industry to bring like minds together and make a more efficient package. Sometimes it works, and I will tell you, sometimes it doesn't. I was president of Rochester General when Genesee became part of that system, and that did not work well, and Genesee wound up closing. Well, they built a lot of things. Yeah, they built a brand new birthing center, and Yeah. No, you're absolutely right. Well, as president of Rochester General, I have to push back on that. I don't think that Rochester General had much to do with it because that actually happened 7 or 8 months after the merger. So it happened very quickly, and it was really a function of overcapacity and other issues within the community.
We have another question in the back.
Okay, I actually have two very distinct questions. One is, are there any facilities that have gone through all this adjustment and are like at the end of the road and maybe in this area or somewhere in New York that are role models per se to be looking at, and how are they doing? Is there anything similar to our area where there were multiple facilities that kind of collaborated, and is anybody at the point where it's moving forward now in business, not business as usual, but moving on and not just continuing to work out kinks? So that's one question, and then if you want to address that, I have another.
I'll just mention, as I mentioned before, we've been involved with Brockport, where Lakeside Hospital closed, and Lakeside Hospital found itself, it simply ran out of cash, and it went bankrupt and closed. We acquired the campus, and we're in the process of renovating the campus. We're building an ambulatory surgery center, a freestanding emergency department. We have an urgency center there now, and certain specialists we've been renovating some space to put their offices there to serve that community, and we have a number of primary care practices within the community. How successful it's been, too early to tell. It hasn't opened. The ambulatory surgery will open July 28th, I think, or somewhere like that. But the clinics and we have an oncology center there are open, and they're doing very well. So I'm very hopeful. It has been a long process. We've had to go through a lot of state approvals to have all this happen. The community has been very welcoming, and I'm hopeful that they will support our efforts over time. We do have similar issues or close issues with Unity Hospital, which has services there and attempts to move services away from Brockport. So we have some of the same issues there, but we're involved, and time will tell.
The other question I have is, I've heard on more than one occasion as the rumor mill goes, if you could address individuals that are stating, just wait till Strong gets here, they're going to clean out house because there can't be two of everything, and they're just going to come down and implement their ways and get out while you can. How can one address that to the employees?
Well, I don't even know how to. The question was the suggestion that just wait till Strong gets here, they'll implement their way. I would love to understand what that way is. I will tell you that I have a number of board of directors that ask me that question with some frequency, and a lot of employees. Our goal is really to make sense with the Department of Health of how services can be provided, and with your board of directors and Jen and Stan, and try and make sense of that, and your medical staff. I don't know how successful this is going to be over time. We're going to do everything we can to make sense of it. I don't know what else I can say. We don't have any unique ways. Our approach is very simple. When there's a defined need, we try and bring in the specialists or the primary care physicians or others. I know you have very fine primary care physicians, and you have very fine specialists within the community. So we're not really anticipating that. Right now, the first focus is where will they practice? Will they be in their office? But when they have to admit patients, how will that work? If they have to use healthcare facilities, where will that be? What will they look like? Do they have to be transformed? Jen mentioned that the state was going to be supporting the facility. We don't know how long. We don't know the renovation that has to be done in the future and how that will play out. So we're really in the beginning stages of this. And I really commend the board and the medical staff and Jen and Stan for wanting to share that with the community. I know it's very uncertain, but the reality is that when you don't even talk about it, there's always rumors and assumptions. And I can tell you that what was stated here is where we are. And over the next months, you're going to see more definitiveness, good and bad, but you will see more definitiveness to this. And one of the dilemmas that we're caught in is trying to create a plan with every other part of the state trying to create a plan as well, and have a Department of Health make sense of that, and then commit long-term resources for specific points of that. So we're not the only one at the table. And I can tell you that having experienced Jen's phone calls almost on a daily basis of what are you doing for us today, she is constantly talking with the Department of Health, trying to push them along so that she and Stan and your board can really bring some definitiveness to what is right now a very cloudy, but not unusual, given where we are, a very cloudy situation. Yes.
Hi, this is sort of a vision question. I have some experience as an NIH researcher studying numbers of high-risk infants who had laid prenatal care, and in following them up over years, I was thinking that the way you're talking about prevention, there's 3 levels of prevention in general: primary, secondary, and tertiary. And frequently, we all start as babies, of course. We wind up in hospitals in a tertiary situation rather than having intervened, identified very early. And what struck me is how inexpensive primary prevention, is compared to secondary or tertiary. And I've also noticed how many children wind up in school at 5 or 6 when a little tweaking when they were infants or toddlers would have made a heck of a difference in terms of their visual or auditory or other developmental skills. So one of the things I've wondered is, and this is void of infrastructure, in other words, the palette would be open in terms of how you apply the existing healthcare infrastructure, is how could we use, let's say, the current, as I understand, electronic birth certificate system in New York State to use that to identify all newborns and then try to subtract from that those that, for example, are getting vaccinations and other primary well baby visits, to find all of those who I found in my research who missed and fell through the cracks and oftentimes didn't show up until kindergarten. So perhaps Mr. Goldstein, could address that kind of vision thing and how the state or regional hospitals might address it.
Sure. I'm going to stay sitting.
You know, I'm going to introduce Kathy Perinello, who's our Chief Operating Officer, but also was Director of Surgical Nursing and has had a great deal of experience. But I will comment, you really hit a nerve for me at a personal level. We had a grandson who spent 124 days in a NICU, and we're now at the 2.5-year mark, and we're fighting like mad. He lives in a different state, fighting like mad to make sure that he has services as you described, because we know that if not tackled early, it can result, communication issues or other issues can really result in problems later on. And depending upon the funding of schools and the availability of schools and their ability to provide special needs, can have tremendous ramifications for children. So one of the things that we've been talking about is tomorrow morning, actually, I was just commenting at 8 o'clock, I'm actually giving a talk to our Department of Pediatrics and all of their faculty and researchers to try and describe the application that we're going through, and the span of regions that we're talking to, so that they're aware from developmental point of view and pediatric point of view what services might be provided to many of those communities as they try and address those very, very difficult issues. And so many of those issues have to do with local resource and the ability of parents to really push and make sure that their child or grandchild, whatever, has the benefit of those resources. You have to be an advocate because sometimes the systems push back. Kathy, do you want to make a comment?
You've all heard Jen and Steve talk about DSRIP, which is that state program that's designed to help restructure the healthcare system in New York State. And even though the challenge with that program is it's just evolving, with applications due at the end of June, so not a lot of specifics yet, it is very clear that the purpose of that initiative, and as lead applicant working with Jen and her team in Hornell, as well as many other regional providers, it is very clear as we're preparing for that application that the things the state wants to fund, the things the state wants us to spend money on and devote time and energy to, are exactly what you described. It's the prevention agenda. You know, basically New York State is saying, you know, we're making lots of investments in hospitals. Historically, we made lots of investments in hospitals. We need to taper those investments in hospitals. We need to support those that are challenged while they make the transition. But we need to level our investment in hospitals. We need to increase our investments in outpatient services. Things like urgent care, emergency care, behavioral health, primary care, multi-specialty outpatient clinics, physical therapy, well child care. Nurse-family partnership is a program you may know about that's pretty well developed in Monroe County, needs to get more well developed here, and that's where at-risk children have a nurse assigned, and one nurse can manage up to 20 or 30 families, and they work with that family to make sure all the immunizations are given on time, nutrition is attended to. So even though we've got a lot of time between now and when we'll actually see some of these initiatives roll out because of the way the state program is evolving, much of the initiative and the incentives in this program are designed to do many of the things you just described. So we're real excited to be working with all of our partners in the region and trying to bring those services.
What I was trying to suggest was an at-risk registry.
Yeah.
Where you would actually not just go to the parents who are advocating for the child, but the vast majority of the folks that I had the privilege of working with in a more urban area had no idea what the issues were. I mean, their parents had never gone for prenatal care, or last time they had a baby without it, or they were a 16-year-old and their 32-year-old mother had had them when they were 16, and so they knew they couldn't even tell their mother that they were pregnant. So the first time the mother found out was when she got a call from the hospital saying, "You have a grandchild."
Right. And that's exactly the way some of these programs work. Obviously, the first step is risk identification, and then the second step is what kind of community services can you put into place to help those families so that they don't have significant illnesses later in life.
I think we're over our time. We could take one more question, and I apologize, but thank you for staying. It's been a wonderful evening, and I hope this was a helpful update for you. Okay. Oh.
Is there a timeline, any sort of a timeline you can find for when all this will take place?
There's timelines for when the applications are due for the funding that we're seeking to sustain operations. That's due by the end of this month, May. We know we'll find out if we get the funding in June. We know this, the DSRIP application that Kathy and Steve were talking about, that's due in December. So a lot is being driven by these timelines related to the, those two programs. And so, you know, when we talk about sustaining operations through early 2015, we're typically talking about a state fiscal year, so that's through March 31 of 2015. In terms of the path and the pace at which the details will come together, I can't tell you because it's dependent on a lot of organizations outside the span of my control. So, you know, it's evolving day by day, but I can tell you, you'll see a lot of movement between now and the end of the year on these applications and where we're heading directionally.
I'm glad to have the opportunity to talk to you because I belong to a group in New York State, the ARC, that already has many of the programs that the president of the Shuvar mentioned. And actually, to take advantage of all those that are already taken place and have been successful in their endeavor, don't fail to utilize what's already available and blind yourself to the possibilities of working within them.
Agree with you completely. Thank you.
Jen, I'm the representative of the 9th Ward, in which St. James sits, you know, smack dab in the middle of. And one question that I've been bombarded with is, if you get a new facility, what happens to the old facility and all the parking lots?
That's a great question. What we have put together is a facility reuse study, so there are reuse options for the facility. What it would ultimately become, I'm not sure, but that's a whole nother project in and of itself. But really, that's the path of the next step is to, you know, look at a facility reuse study and say what are the uses for that and what would make the most sense. So we'd be working with, you know, the IDA and others in the area on that. So I guess one step at a time, but you're right, it's a whole nother project.
Thank you.
Hi, Neva.
I currently work at St. James, and I would just like to say thank you to all of you that have worked so hard and diligently to keep our facility going for the community. And there's been many changes, and they've been all positive changes, and everybody needs to come in and really experience everything that's been going on. And thank you.
And that's a perfect time to tell you that we have a showcase of services next Wednesday. It's the May 28th from 3 to 6 at the hospital. So please, if you're free, come on over, see what we're doing. And I thank you, Neva, for your comments. That was much appreciated. Thank you all for coming tonight. We look forward to seeing you again in August.